Let's talk about prevention of RSD alloimmunization. Causes 10% with threatened abortion and 50% giving birth in the third trimester have fetal maternal hemorrhage. Volume needed for alloimmunization can be as low as zero point 0.1 milliliter. Anti-D immunoglobulin should be administered within 72 hours of disruption in the choriodecidual space. The half-life is 23 days. Volume as little as zero point 0.1 milliliter can cause alloimmunization. Recommend anti-D immunoglobulin after CVS. Um, CVS has about 15% risk of fetal maternal hemorrhage. Amniocentesis has 5%. External cephalic version has about 5%. 2% chance of alloimmunization after a spontaneous abortion, 5% after a DNC. So prevention, we administer anti-D immunoglobulin at 28 weeks. And after the birth, if the fetus is found to be Rh positive, there's a 2% risk of asymptomatic alloimmunization. And because of that, we do the prophylactic dose. 300 microgram of RhoGAM can counter about 30 cc of fetal whole blood. If it's greater than 30 cc of fetal blood in the maternal blood, it will need a Kleinhauer Betke or flow cytometry to quantify the amount by examining the fetal globulin F concentration in the maternal blood. This is done postpartum, and you can do a rosette test on the maternal blood, and then if it's positive, then you use the Kleinhauer Betke test to quantify the amount, and then you give additional RhoGAM every Q12 hours up to 8 vials. Routine screening of fetal Rh status is not recommended due to cost effectiveness of non-conclusive results. So Rh antibody positive woman, if it's due to conversion from previous RhoGAM, then you can continue to give RhoGAM as protocol. If conversion is due to true seroconversion, there's no benefit in giving extra RhoGAM. Pregnancy. What other situations should you give our anti-D immunoglobulin? So pregnancy loss or abortion, the patient should receive at least 120 micrograms if the pregnancy loss is before 12 weeks. After 12 weeks, it should be 300 micrograms. Molar pregnancy should be patients should be receiving anti-D immunoglobulin. Atopics also should get immunoglobulin regardless the route of treatment for the atopic. Weak RHD these patients are considered Rh negative and will be getting RhoGAM. But if they're given blood, they're considered Rh positive. but if they are the recipient of blood, they are considered Rh negative. And also in terms of pregnancy, they're considered Rh negative and given RhoGAM just in case. Bleeding in the second and third trimester after 20 weeks, they should be receiving RhoGAM. Chronic hemorrhage, every 3 weeks, we do a Coombs test. If positive, after RhoGAM, which tests every 3 weeks with Coombs test, if positive, this indicate there is still anti-D immunoglobulin. However, if they're negative, which indicates there is no more immunoglobulin, and RhoGAM should be given again. Recommendations: we should repeat the Rh evaluation at 24 to 28 weeks before giving RhoGAM in case they have seroconverted. In the case, so to conclude, or the indicated situation where administration of anti-D immunoglobulin is indicated, so CVS, amnio, external cephalic version, spontaneous missed abortion, abdominal trauma, they should be given RhoGAM, but we should do a KB test to see if additional doses is necessary. Second trimester fetal death, postpartum sterilization in a Rh negative woman. Can be given as late as 28 days after exposure, but ideally less than 72 hours.